All right, well, welcome everyone. Thanks for joining us here at noon. Hope everyone's off to a nice summer. So pleased to introduce Dr. Vaishnav today to talk about overlooked and underappreciated and treatable conditions. Dr. Vaishnav is a graduate of fellowships in cardiology here at Johns Hopkins Hospital, is currently the director of the Johns Hopkins Comprehensive Amyloidosis Center. Thank you, and we look forward to learning from you today.
Thank you. And I see I'm doing presenter view. Let me try to. Is that looking any better or still? Okay. Okay, perfect. Good afternoon, everyone. Thank you so much for having me to your grand rounds to talk about a topic I'm very passionate about. We're going to be focusing on amyloidosis with a little bit more emphasis on transthyretin amyloidosis today. As you heard, I'm one of the advanced heart failure and transplant cardiologists here at Hopkins, so I've interfaced with many of you through that, our transplant patients, but I also direct our amyloidosis center. Here are my disclosures, and moving into the outline for today. We are going to review just basic background of transthyretin amyloidosis. I think very important to highlight that this condition is underdiagnosed, and we'll talk about what are the key tenets that lead to the underdiagnosis. We'll touch on the diagnostic algorithm of cardiac amyloidosis, highlight current and emerging therapies, and then I'm very excited and grateful that we will have a patient joining us today to share his perspective of living with amyloidosis, Dr. Sharni Rucker. So thank you, Dr. Rucker, for joining us today at the end of the talk. So I think we should start out with kind of the ever important question, maybe the elephant in the room, of why are we discussing amyloidosis at PM&R grand rounds and rather than cardiology grand rounds? Well, amyloidosis is very much a systemic condition. The initial suspicion and ultimately diagnosis actually spans across many different subspecialties, not just cardiology. And yet, I think this is somewhat what contributes to the underdiagnosis of the condition, that it can have such a heterogeneous presentation. And so it's systemic, yet underdiagnosed. And when underdiagnosed, it's highly progressive. And so early diagnosis is certainly key to improving outcomes. Moving into just basic terminology and background, what is amyloid? Amyloid is a generic term we use for any protein that's capable of misfolding, specifically into beta-pleated sheets, and then become resistant to proteolysis and can ultimately deposit in various organs. When we're invoking someone has cardiac amyloidosis, we're saying these amyloid proteins have accumulated in the myocardium, leading to heart failure, valvular disease, and arrhythmias. Shown here is kind of the ultrastructure of the amyloid fibril. And then on these pathology slides, you can see actually the amyloid deposition in the myocardium. It's this amorphous, salmon-y pink substance. And then with Congo red staining under polarized light microscopy, you get that pathognomonic apple green birefringence. So while there are many different types of proteins that can cause amyloidosis, I'm going to be focusing this talk on the types of proteins that tend to cause cardiac disease. So about more than 95% of the time, cardiac amyloidosis is caused either by deposition of AL light or light chains or transthyretin known as TTR. In light chain amyloidosis, the abnormal cell originates from the plasma cells, and they are either kappa or lambda light chains. These kappa or lambda light chains can then misfold and deposit in a variety of organs. The kappa and lambda light chains are, clonal production puts AL amyloidosis on the spectrum of other plasma cell dyscrasias. So there is overlap with MGUS, a very common condition, monoclonal gammopathy of uncertain significance, as well as multiple myeloma, which is less common, but of course more fatal. So MGUS, multiple myeloma, AL amyloidosis, they all overlap, but do have discrepant clinical features and treatments to some extent. Contrast AL amyloidosis to transthyretin amyloidosis, the far more common type of amyloid that we're tending to diagnose. Transthyretin amyloidosis is caused either by a point mutation in the TTR gene, known as hereditary TTR, or age-related changes known as wild-type TTR. Transthyretin, the protein, is predominantly produced in the liver, and it serves to transport thyroxine and vitamin A. In its healthy configuration, it's a tetramer or a four-leaf clover. But then when amyloid occurs, this stable, healthy configuration of the tetramer dissociates into monomers and then forms the fibrils, which then go on to deposit in other organs. And so this cascade is just helpful to know because this is the very cascade we've manipulated to develop all the effective therapies we have today. So moving into the actual pathophysiology, so what happens when amyloid deposits in the myocardium? So a few impairments happen. One is there can be direct cytotoxicity of the amyloid fibrils, which can lead to myocardial necrosis and heart failure. And then there's also mechanical disruption of the myocardium. So this is what leads to the classic findings we see on imaging, such as left ventricular hypertrophy and diastolic dysfunction. So it's a combination of these factors that lead to the heart failure. You can see here a gross pathology specimen of a heart with amyloid and appreciate thickened walls, a small left ventricular cavity, and then a large left atria as well. So this is what we tend to see on gross pathology in folks with amyloidosis. So in terms of the disease course, this will be heavily dictated by the type of amyloid present and the type of protein causing the amyloid. So in AL or light chain amyloid, again, caused by either the kappa or lambda light chain being produced in a clonal fashion, there's a broad age range. It can affect younger to older individuals, a slight male predominance. And this is a condition that I would consider to be a diagnostic emergency if suspected, because untreated survival can be as low as 6 months, and it tends to be much more rapidly progressive compared to TTR. Cardiac involvement is common. It's present in the majority of the cases, about 60% of the time, though other organs can certainly be affected. Now, hereditary TTR, again, caused by a point mutation in the TTR gene, also can have a broad age range, but age is a risk factor for developing phenotypic disease. There does tend to be more of a male predominance. And the clinical course, which we'll get into, can vary considerably depending on the specific variant in a family and how aggressive it is. However, median untreated survival, specifically in the cardiac variants, can be as low as two years. And then lastly, we have wild type TTR, the TTR that's caused by the age-related changes in the TTR protein. This does tend to affect elderly individuals ranging from 60, though oftentimes I'm seeing patients 80, 90 years old with newly diagnosed wild type TTR amyloid. Heavily male predominant, and compared to the other subtypes tends to be more slowly progressive with an untreated survival of 3 to 5 years. So it's important to kind of understand the genetics of TTR cardiomyopathy because it is one's genotype that will ultimately dictate the phenotype of the disease. So as you can see from this schematic, there are certain variants that tend to be heavily neuropathic and will present primarily as a peripheral neuropathy. Other variants tend to be heavily cardiomyopathic, presenting first as heart failure. And then many variants tend to be mixed, which can either present with neuropathy, cardiomyopathy, or both. Again, these variants, these are point mutations in the TTR gene that are inherited in an autosomal dominant fashion. Though the penetrance and expressivity will vary quite a bit. And they do tend to have a regional preference. So various regions are associated with specific variants as well. So I wanted to, I think that's general background that'll kind of set us up for the rest of the talk. But I really did want to spend time on discussing the tenets that lead to underdiagnosis of cardiac amyloidosis. And I'm going to start with a case. This is unfortunately not an uncommon case that representative of what I see. So this was a woman who was seen here at Hopkins. She was a 78-year-old African-American female. She had a history of a cardioembolic stroke 2 years prior. But when I met her, she was presenting 2 years later with acute decompensated heart failure. So you can see in the echo images, at the time of her stroke, she had a cardiac workup. Her echo was abnormal. It had mild left ventricular hypertrophy, generally a preserved ejection fraction. And then as part of her workup, she had cardiac biomarkers that were checked, a proBNP and troponin, which were in fact abnormal, but mildly so. She was recommended to follow up with cardiology on discharge from the stroke service, but unfortunately that didn't happen. And 2 years later now, she's presenting with features of cardiogenic shock. She had, as you can see, a dramatic change in her left ventricular heart function, now severely reduced. Her heart walls are much more thickened, and she has biatrial enlargement. Her cardiac biomarkers are now off the charts abnormal, and she was very symptomatic. So at the time of her stroke, her echo was not read as overtly suspicious for amyloid. However, by the time she presented with heart failure, her echo was read as highly suspicious for amyloid, which prompted a subsequent workup. She had a typical workup for cardiac amyloidosis, which I'll cover later, but that included a PYP scan and light chain testing. She did have genetics as well. I didn't put that on the slide. She was tested positive for the V122I variant that I'll touch on later. And unfortunately, her course was not favorable. She was discharged to subacute rehab, but too ill to make it to my follow-up and died within 1 year of her amyloid diagnosis. So I think this case certainly highlights just the fatality of missing a diagnosis, and also the under recognition, even under our nose here at Hopkins. This went under recognized. So why is amyloidosis so underdiagnosed? I think probably the most common explanation, the most commonly encountered situation that I see is that the symptoms can be quite nonspecific, especially at the start. Maybe mild dyspnea, mild neuropathy, and varies quite a bit from patient to patient. Amyloid can certainly mimic other cardiac and non-cardiac conditions. And I think there is a general lack of awareness among both cardiology and non-cardiology providers, just among healthcare practitioners in general. And I think part of the motivation for this talk today is to make headway on that. I think the more we hear about amyloid, the more you'll think about it. And if you don't know about amyloid, you're certainly not going to think about it. So kind of trying to improve the awareness of this condition. So what are some of the statistics on underdiagnosis? We did look at our data. This isn't our data here, but we found that from time of symptom onset in the chart, when someone maybe first reported dyspnea to diagnosis, there was on average a 2-year delay. That was more pronounced in TTR, probably because it's more slowly progressive. In a literature review, it was shown that up to 57% of patients are given an alternative cardiac diagnosis before being confirmed to have amyloid. So the most common misdiagnoses are hypertensive heart disease, hypertrophic cardiomyopathy, or heart failure with preserved ejection fraction. And I'll talk about the non-cardiac ones as well in a little bit. And patients are often cycling through providers trying to figure out what's wrong. So often seeing multiple, more than 5 to 10 providers before ultimately being given their amyloid diagnosis. So I think part of diagnosing amyloidosis, really the hardest part is actually first suspecting it, knowing when to suspect amyloidosis, when to think about calling a cardiologist or an amyloid provider to work this up further. I'll touch on the cardiac clues, but I think probably more relevant for our audience today are the non-cardiac clues. So we'll spend more time on that. But from a cardiac perspective, who do we suspect amyloid in? Really any patient with heart failure, if they have that left ventricular hypertrophy on echo or cardiac MRI, and typically they're not dilated patients. These are patients where certainly amyloid should be in the differential. We talked about HFpEF being kind of an umbrella term given to a lot of patients. And HFpEF, meaning heart failure with preserved ejection fraction, is common, but amyloid patients are often diagnosed with this when they lack the typical risk factors for HFpEF: obesity, diabetes, uncontrolled hypertension. And so this is another red flag. Amyloid patients tend to be intolerant of standard guideline-directed medical therapy used for non-amyloid heart failure that causes hypotension. Amyloid patients tend to have a persistent low-level troponin elevation. These are patients who you'll see N-STEMI ×4 in the chart, no coronary disease detected. That's a red flag. And then atrial arrhythmias and conduction disease is another cardiac red flag. But I think importantly, recognizing the extracardiac clues is probably what can actually lead to an earlier diagnosis before someone has the onset of overt heart disease. So what are the extracardiac clues of amyloidosis? So TTR can deposit in a variety of different joints, and besides the heart, tends to affect the peripheral nerves. So there are a variety of musculoskeletal or orthopedic red flags in which to consider TTR amyloid. Bilateral carpal tunnel syndrome, I'll talk about that in a little bit, is a red flag for amyloid. Lumbar spinal stenosis, someone who's either has this diagnosis or has undergone surgery for lumbar spinal stenosis, is another red flag. Probably considered pathognomonic at this point is biceps tendon rupture. This tends to happen somewhat spontaneously in patients with amyloid. They weren't doing a whole lot. They were lifting a bag, maybe carrying something heavy, and rupture their biceps tendon. Patients who have had a variety of arthroscopies, arthroplasties, joint replacements is actually another red flag for amyloid. And then patients who have had multiple treatments for trigger finger. So these are the orthopedic manifestations or red flags for TTR amyloidosis. And it's related to the amyloid protein actually depositing in these spaces and causing the vulnerability or the symptoms. Polyneuropathy tends to be common in hereditary TTR, and peripheral neuropathy can also manifest as autonomic dysfunction, which I'll talk about in a little bit. AL amyloidosis, the dysfunction here is also related to the light chain proteins being able to deposit in a variety of organs. Also can cause neuropathy, GI manifestations, kidney disease, liver disease, etc. And so this tends to be widely systemic. Shown here are two of the pathognomonic features of AL amyloidosis. One is periorbital purpura. So these are the raccoon eyes that patients can develop related to the vascular fragility around in these vessels. And then macroglossia is another red flag for AL, has been shown in TTR as well, related to the amyloid deposition. So moving into specific features of the extracardiac manifestations of amyloid, and I'll start with peripheral neuropathy, which probably is commonly encountered in a variety of settings in your specialty. So peripheral neuropathy can be the initial presentation preceding cardiac onset or at the same time of cardiac onset in TTR or AL. Most commonly, though, associates with hereditary TTR disease. What we tend to see clinically is axonal deposition leading to a sensory motor polyneuropathy, and this can be accompanied with autonomic dysfunction as well. Common misdiagnoses, CIDP and Charcot-Marie-Tooth. So these are common, amyloid can mimic these diseases, but some distinctions. Certainly if you have a patient who's been diagnosed with CIDP and is not responding to immunotherapy, that's a patient to consider a misdiagnosis in. And then the diagnosis of CIDP with autonomic symptoms would be considered a red flag for amyloid. So I think certainly important to test or think about amyloid in patients who have these conditions and maybe haven't responded to the standard treatment. Early on, amyloid deposition tends to cause a small fiber neuropathy, and then this can progress to then symptoms of a large fiber neuropathy. And so symptomatically, what we see is, again, early on pain and maybe thermal sensation discomfort, which begins in the feet and then extends proximally. And then this can progress untreated to overt gait instability and severe debility. In terms of the diagnosis of TTR peripheral neuropathy, standard tests, including nerve conduction studies, EMG, and skin biopsy as well, especially for those with early disease where you may not detect overt changes on nerve conduction study. And it really is, it's a clinical diagnosis, meaning, you need to exclude other probably more common causes of neuropathy, such as diabetic neuropathy, et cetera. And so in these pictures here are classic, this is from a patient with hereditary TTR polyneuropathy. You can see classic skin changes, mild edema, some discoloration, and then this patient had bilateral foot drop as well, shown in the bottom graphic. Autonomic dysfunction is unfortunately common in patients with TTR and AL, related to, again, deposition of the amyloid fibrils, impairing the autonomic nervous system. Common symptoms associated with autonomic dysfunction from early to late here. So early on, you can see GI symptoms with a copious secretory diarrhea or diarrhea alternating with constipation. Many patients have erectile dysfunction, again, that temperature sensitivity or dishydrosis. And then orthostatic hypotension can be particularly debilitating. And orthostatic hypotension tends to limit our ability to treat the heart failure that is often present as well. So obviously diuretics are going to be less well tolerated in patients who have orthostatic hypotension related to their amyloid. How we grade severity, there are a few different scales just for awareness to grade TTR polyneuropathy severity, including the FAP stage, the familial amyloid polyneuropathy stage, as well as the PND score. And you can see here, patients can range from being completely asymptomatic all the way to bedridden or wheelchair bound, depending on how severe their disease is. And then I highlight here data from the TAUS survey. This is a Transthyretin Amyloidosis Outcome Survey. This was a global longitudinal registry that included hereditary and wild type TTR patients, and kind of in this particular study quantified burden of neuropathy symptoms. And as you can see here, I flipped the graphic just for us to see, but they split the cohort into a particular variant, V30M, that tends to be very neuropathic, and included wild type patients as well. And you can see that the frequency of autonomic dysfunction is common: early satiety, diarrhea, erectile dysfunction, et cetera. Erectile dysfunction shown up to 67% of patients with early onset V30M. So there certainly is a high burden of autonomic dysfunction in hereditary and wild type TTR patients. And certainly the presence of autonomic dysfunction does impact quality of life. So in the same paper, they associated those who had an autonomic dysfunction versus not, and compare the Norfolk quality of life questionnaire, with the higher score being more impaired. And you can see clearly if patients had dark blue autonomic dysfunction, they had a worse quality of life across all the different domains. So a very important and unfortunate source of impairment in functional status and quality of life in our TTR patients. So moving now on to another, I think, orthopedic red flag that we commonly encounter, bilateral carpal tunnel syndrome. So this is common in TTR, shown in AL as well, but more robustly described in TTR. And importantly, often precedes the onset of cardiac disease by up to 10 years. So can certainly be a way to diagnose amyloid in the heart earlier than we would otherwise. How common is it? It's been described in up to 60% of patients who are ultimately diagnosed with wild type cardiac disease. And why this occurs, again, if amyloid has a propensity to deposit in areas of wear and tear. And so that would include the flexor tenosynovium, transverse carpal tunnel ligament, and these are small spaces, so it only takes a little bit of amyloid deposition to cause symptoms. It is treated similar to non-amyloid carpal tunnel syndrome in that patients undergo, conservative measures or many patients require a release. But importantly, if you have a patient with bilateral carpal tunnel syndrome, think about if amyloid could be occurring. So of course, this red flag has brought up a question of, well, should we screen patients with bilateral carpal tunnel syndrome for cardiac disease? The Cactus trial published in 2022 in JACC did look at this to some extent. So this trial investigated patients who had a history of bilateral carpal tunnel syndrome, so patients specifically who were who had undergone a second intervention for carpal tunnel syndrome 5 to 15 years prior to enrollment in the study, ranging from 60 to 85 years old. 250 patients were studied, and it was a heavily female predominant cohort compared to the TTR demographic, which is more male predominant, and I think that did impact the results. So in all comers, when looking at patients who were diagnosed with bilateral carpal tunnel syndrome 5 to 15 years earlier, and when screened, 5% were found to have wild type TTR, though when they sort of varied the cohort by known risk factors, male, elderly male specifically, that clinical yield for screening was higher, up to 20%. So I think certainly it is a way, it is a kind of a way to detect amyloid disease earlier. And there have been screening algorithms detected at various institutions. I show here a published algorithm from Cleveland Clinic based on their data. So what does screening look like? Well, it means that when a patient's undergoing surgery for their carpal tunnel syndrome, you actually proactively send the tissue to look for amyloid in the tenosynovium. And so what is an example of a screening protocol? Well, you have to be above a certain age to be in that category of risk. So men about 50, females about 60, and or have bilateral carpal tunnel syndrome. And then Cleveland in particular paired this with other known risk factors for amyloid, which I highlight here, to decide if patients should have tissue sent off at the time of their carpal tunnel release. When tissue is sent off, then you look for the amyloid deposition with Congo red staining. And then if you detect amyloid, that will ultimately be sent for mass spectrometry to tell you what type of amyloid. Is this TTR, is this AL, et cetera. And certainly if you detect amyloid, that should prompt referral to an amyloid center. And so I've personally seen an uptick in this referral patient population. I think it's good because we are catching it earlier. Though I think we have to balance that with the anxiety of telling someone they have amyloid in their wrist, but not in their heart, maybe 10 to 15 years before they get it in their heart. So I think we're all kind of navigating this landscape. And I show here in this picture kind of how we approach this currently, which is certainly if you have amyloid in your wrist, we can say that's a risk factor for subsequent development of heart disease. But we don't think certainly I don't think we can say 100% of patients will go on to develop heart disease. It's just a risk factor. And so we are not yet, I personally screen for heart disease in those patients who have amyloid in their carpal tunnel to look for it, and then do serial screening depending on their age annually, every 2 years, et cetera. But as a community, we are not yet treating amyloid if it's only identified in the wrist and not in the heart. However, that may be the way of the future. One may say, why wait for it to develop in the heart? And if we know it's circulating in my body, should we treat it at that stage? So I think there will be more to come on this, and it's definitely an evolving landscape. Okay, so I wanted to shift now to kind of a unique at-risk patient population, African Americans with cardiac amyloidosis, and cover kind of another tenet of why amyloid is underdiagnosed. I think there is certainly a perception that cardiac amyloidosis is a zebra, rare disease. Maybe I'll see it once, maybe not at all. And I think that's just not true. AL, light chain amyloid, is technically kind of an orphan net disease with less than 10,000 cases diagnosed per year. But TTR is by no means a zebra. It's more of a horse. And we've really realized this in the past 10 to 15 years with increased diagnostic capacity. So, we actually don't know the true prevalence of TTR, but just to give you rough estimates, it's been detected in up to 15% of men above the age of 60 living with HFpEF. That's a vast majority of patients. And then related to that V122I variant, 3 to 4% of African Americans living in the US have this variant. And so I want to spend some time, because our patient population tends to be very much affected by V122I hereditary TTR, talking about this special patient population, which I consider a special beast of a disease. V122I is the most common variant, TTR variant we see in the United States. So you can see here in this pie chart, a distribution of variants shown in the US compared to the rest of the world. So in the US, wild type is still the most common form of amyloid, but of the hereditary type, V122I is most common, and that's different from the rest of the world. V122I TTR cardiomyopathy causes predominantly cardiac disease and almost exclusively affects people of African or Afro-Caribbean or Hispanic descent. So if we do the math, it's estimated to be present, or about 1.5 million African Americans are estimated to be carriers of this variant, again, with variable penetrance and expressivity. And why does this matter? Well, it's common, it's underdetected, and unfortunately, V122I patients do worse. They have worse survival, looked in multiple different cohorts, which I show here. So on the first panel, you can see data from TAUS, that survey, that longitudinal registry I had mentioned, comparing the incidence of heart transplant and wild type versus V122I, with a much higher frequency of heart transplant needed in V122I. Data from Boston University, a large amyloidosis center, also showed inferior survival in V122I patients by more than a year. And then a UK cohort, which I'll cover a little bit later, also showed the worst survival compared to non-V122I and wild type in V122I patients. Median survival was 31 months. And these were largely untreated patients. And so I think, of course, this begs the question, well, why? Why do patients with this particular variant do worse? Is it pathobiology? I don't think we can ignore the fact that there may be socioeconomic disparities contributing, as well as perhaps a higher burden of other cardiac and non-cardiac comorbidities. And so this has been investigated in various studies. And I'll first talk about the pathobiology. I think we do have data to suggest that V122I TTR is a more aggressive form of amyloid compared to wild type. In the UK cohort I previously mentioned, you saw that disease outcomes were worse in V122I. And the authors argued that this was despite kind of free access to healthcare that should not be related to a disparity issue. And in fact, V122I patients did present with more severe disease characteristics at baseline. And there was actually a shorter diagnostic delay from first symptom onset to from cardiac disease diagnosis. And I think this speaks to the fact that probably once patients have amyloid deposition, they become symptomatic sooner compared to wild type. V122I genotype in this paper was predictive of mortality independent of disease stage. And so you can see here their multivariable model looking at predictors of survival with a significantly higher hazard for death in V122I patients. But I think there are probably other explanations beyond just pathobiology, and these are where other cohorts have shown, have elucidated this. So looking specifically at racial differences, well, this is a hard analysis to do because very few white patients actually have this variant. However, there is uniquely a cluster of patients in Northern Italy who have been identified to have V122I TTR-CM. And in fact, when this cohort was compared to Black patients living in the US, there was a significant difference in outcomes with Black patients doing worse. So I think that does speak to some differences by race. And then we explored the specific question of, the contribution of socioeconomic status in our cohort. So we looked at the association of race and SES with outcomes. I show here, one, that patients who are more socioeconomically deprived, as we measured by ADI, area of deprivation index, probably don't even need us. So group 1 was the least deprived category compared to group 3, most deprived. And you can see the vast majority of patients we're treating are less socioeconomically deprived. And this probably is not specific to amyloid. And then of the patients who are in the most socioeconomically deprived group, these were predominantly African-American patients. So it highlights a disparity there. When we compared outcomes by race, we show that African-American patients do worse in terms of survival and heart failure hospitalization. And when we stratified by socioeconomic status, you can see African-American patients with a high ADI, most socioeconomically deprived, had the worst outcome. So certainly there's I think, again, a variety of explanations for why this variant is so highly morbid. In our multivariable analysis, in patients who are more socioeconomically deprived, as measured by a high ADI, Black patients did worse compared to white patients, even when adjusting for disease stage, et cetera. So I think more work needs to be done to investigate this and ultimately improve what we've identified. And so beyond our analyses, I highlight that there certainly is a disparity in diagnosis by race and ethnicity. So this is an interesting and important paper done by Kevin Alexander, who's an alum from our residency program, basically looked at mortality trends using the National Vital Statistics System by race for amyloidosis. So shown here are certainly Black patients have a higher reported mortality from amyloidosis, but when actually stratified by geography, the lowest reported mortality was in the regions with the highest proportion of African-American residents. So I think the take home being not that patients are dying less in these states, but rather it's likely underdiagnosed and underdetected. I think that's particularly true of the southern regions of the US. Despite this, African-American patients are unfortunately underrepresented in TTR cardiomyopathy trials. So you can see here the general breakdown of percentage of patients for as low as 7% in the most contemporary trial, Helios B, and as high as 14%, or as low as, 5%. So underdiagnosed, worse outcomes, yet underrepresented in clinical trials, not a good combination. This is not just true of amyloid. I think this is a phenomenon across certainly cardiology, heart failure trials as well. But I think ever more important to study outcomes of therapies in African-American patients with amyloid, given the worst outcomes we see. So there are efforts being done to kind of increase awareness and detection of TTR amyloidosis in African-American patients, in particular the SCAN-MP trial, basically implementing a screening protocol in Black or Hispanic patients. This study was done in 4 centers in the East Coast, including in New York and Yale. The kind of final, I guess, results of this trial have not been reported, but I think it will help elucidate just the exact prevalence of TTR disease in Black and Hispanic patients in high-risk communities. So that was a whirlwind tour of why amyloid is underdiagnosed. I'm just going to touch on the diagnostic algorithm and therapies, and then I want to leave time for questions and hearing from our patients. So this is the diagnostic algorithm for amyloidosis. I think this gets into the weeds a little bit. I will highlight the first step is just to suspect it, and then most probably someone can take it from there. And so in terms of suspicion, I just want to highlight again who is at risk. Certainly heart failure, patients with and left ventricular hypertrophy, and elderly patients above 65 or 70 are patients who have been deemed at risk for TTR cardiomyopathy. what are the red flag symptoms again to remember from a non-cardiac perspective: polyneuropathy, autonomic dysfunction, the orthopedic manifestations I mentioned, GI symptoms, diarrhea, constipation, and then the cardiac red flags I mentioned. Some of these I haven't. So progressive hypotension or normalization of hypertension is an important red flag, in addition to the others that I mentioned earlier. So the combination of heart failure with a red flag with left ventricular hypertrophy should prompt suspicion for amyloidosis. Once amyloidosis is suspected, the diagnostic algorithm is quite straightforward. We now can diagnose TTR cardiomyopathy non-invasively with a PYP scan. And then light chain amyloidosis does require a tissue biopsy and consultation with hematology and oncology. So the last tenet I'll cover about why cardiac amyloidosis is diagnosed bridges into treatment. I think amyloid, there were no FDA-approved therapies for TTR amyloid prior to 2018. And we've known about the disease for hundreds of years before then. So it took a long time to actually develop effective disease-modifying therapy. And so a common reason I see patients sent to me later than they should, is a misconception that there are no treatments available. Being diagnosed with this won't change your management. You're just going to be treated the same otherwise. This is now, thankfully, not true. We now have very effective therapies for amyloid. Shown here is a summary of all of the clinical trials that have been done just in the past 10 to 15 years. More recently, the trials Helios-B, Attribute-CM, these have all led to sort of expedited FDA approval for drug therapy. For TTR amyloidosis specifically, there are treatments that kind of, again, manipulate all aspects of the cascade that I mentioned earlier. So there are therapies that silence the gene production, the protein production, gene silencers. There are therapies that stabilize the TTR tetramer and prevent dissociation into monomers and ultimately prevent formation of the amyloid fibrils. And then there are therapies being developed in clinical trials that are aiming to actually deplete amyloid deposition from the organs, known as depleters or antifibril therapies, none of which are approved yet, but are all under active investigation. So we now have 3 FDA-approved therapies for TTR cardiomyopathy. I list them here: tafamidis, acoramidis, vutrisiran. These are all they have not been compared head-to-head, but we think at least equally efficacious for the cardiac indication. And so, in terms of the factors, what we decide to prescribe, that'll depend on a variety of factors. Is neuropathy present? What is the patient's preference for each therapy? And then cost and coverage considerations. And I'll end with just highlighting the dramatic progress we've made in the field over the past 10 years related to increased awareness, related to now being able to diagnose amyloid non-invasively with a simple nuclear scan, and related to effective therapies. You can see here, these are superimposed Kaplan-Meier curves from the various clinical trials, showing that even in the placebo arm without treatment, in the ATTRACT trial done in 2013 compared to Helios-B completed in 2023, survival is dramatically better. And I think this is related to earlier diagnosis. And with treatment, survival for amyloid is approaching age-expected mortality. But as I highlight, I think there's a lot of work to be done. This is a schematic put together by Dr. Alexander, what he describes as sort of the leaky faucet of amyloid. Pathologic TTR deposition occurs in other organs and even occurs in the heart well before symptom onset. And I think there's a big lag there. Of course, we know amyloid, or we've learned amyloid is underdiagnosed. And so timely diagnosis is another pitfall. We often do not diagnose this timely enough. The drugs that I mentioned, we do have effective therapies, but they are way more expensive than they should be. And although we here at Hopkins are able to get the vast majority of our patients on treatment at an affordable cost, this is a concern in the broader community. And so even if diagnosed, there can be a gap in terms of getting therapy approved and covered and paid for. So what we do here at Hopkins, we operate with a multidisciplinary approach. As you heard, this is a multidisciplinary team that includes heart failure, neurology, oncology, GI, nephrology, et cetera. And so this is our multidisciplinary team here. I put here the referral pathway. I can email this out. I'm personally happy to see any patient with suspected or confirmed amyloidosis. Does not have to be cardiac disease. As you heard, I'm seeing a lot of patients just with amyloid in their carpal tunnel, and I'm always happy to take referrals. So I'll end with my portion there. And I did want to give time for everyone to hear, probably more powerful than me telling about amyloid is hearing, actually a patient's perspective on living with amyloidosis. And I'm very grateful that Dr. Sharni Rakra is able to join us today, and I wanted to give him the opportunity to share his story.
Am I on?
Yes.
All right. Well, thank you very much, Dr. Vaishnav. That was an excellent, comprehensive talk that I've heard, even after all the webinars that I've gone through. So thank you very much. My name is Sharni. I'm a 68-year-old retired gastroenterologist, and I've been diagnosed with wild-type TTR amyloidosis with polyneuropathy. Dr. Vaishnav has mentioned a lot of the non-cardiac manifestations that can occur with this. I underwent treatment for bilateral carpal tunnel syndrome in 2022, but I had symptoms of carpal tunnel for a few years, including part of the pandemic. And for many years, I wore nighttime wrist braces, which did not help. When I did have my surgery in 2022, neither I nor the orthopedic surgeon thought of amyloidosis as a risk. It was assumed that my bilateral carpal tunnel was associated with my profession, which is doing colonoscopies and endoscopies. So again, it's really hard to diagnose unless you really are aware of it. I was also diagnosed with lumbar stenosis, and it finally came around after I really pressured my orthopedic surgeon and my PCP, saying there is an association with lumbar stenosis and amyloidosis, and they were not convinced that some of the symptoms that I was having was due to amyloidosis or was due to lumbar stenosis. We finally got an MRI, and I do have lumbar stenosis with significant impingement at L4 and L2. So I did undergo an injection at the L4 level, and my symptoms of right-sided back pain and leg pain are significantly better. My diagnosis of amyloidosis was due to the finding of atrial fibrillation on a routine yearly cardiology exam. The cardiologist came in and said, you have AFib and left ventricular hypertrophy on your EKG, and I was totally asymptomatic. So I was really taken back, but eventually the workup with cardiac MRIs and the pyrophosphate scan led to cardiac amyloidosis. Some of the difficult challenges I've had is I had pretty extensive ablation of my heart because of my recurrent atrial fibrillation. And again, that is a big challenge because of the thickening of the ventricles and the dilation of the atria. But I'm now not in AFib. But the other manifestations I've had non-cardiac is peripheral neuropathy with pain, tingling, numbness in my hands and feet, primarily occurring at night. I've also noticed significant muscle atrophy, particularly in my feet, because I wear Birkenstocks at home, and I've noticed that I've had to tighten them. So those are the manifestations. Physical therapy has really helped me, both in terms of dealing with the neuropathy. I underwent what's called an anodyne infrared treatment on my feet and hands, And that has helped with my neuropathy there and the tightness that I was feeling in my hands. But physical therapy is important. Some of the exercises I go through now are for balance and strengthening. And a lot of my myalgias that were occurring in my hands, my thighs and legs have improved significantly. So that's basically my story. I am currently on a silencer, which is indicated for polyneuropathy as well. And we'll see how that works. So again, I think Dr. Vaishnav is right. It is a challenging diagnosis, and you really have to be aware of it. And my example is just my bilateral carpal tunnel syndrome, which I was operated on at least a year and a half before I was actually diagnosed with amyloidosis. That's all I have
Thank
to
you.
say.
Yeah, no, thank you so much. I think your case stood out to me because while we stabilize your cardiac symptoms, we've talked a lot about kind of the non-cardiac symptoms contributing to your quality of life, you know, and functional impairment and the role of therapy, which many of the attendants can speak to in improving that. So
I just have one more comment talking about non-cardiac. I think mental health is a big factor as well. We as physicians and practitioners don't address mental health issues with chronic disease, but that was a big factor for me. I had to educate myself, my family, and also put all my documents and investments and et cetera, in place just to satisfy myself and my family. So that is very important as well.
So that's a great point. And I think I think at any stage, right, palliative care and just symptom relief and processing just the gravity of having a chronic condition is very important with amyloid. So thank you so much. And so that does kind of conclude the talk, but we're Dr. Rucker or I are happy to take questions, comments, experiences with amyloid, anything at all.
Thank you very much for the excellent talk. This has been really revealing because we see so many of the non-cardiac symptoms just routinely. And, you know, we were just, clearly you have screening criteria, but since we see so many of these patients and we may not suspect them at all, do you have any suggestions for what we could do routinely? You know, so clearly if there's bilateral carpal tunnel syndrome and they're going for surgery, there is a protocol. But what type of protocol do you think, you know, could be something that our specialty sees in the community?
No, I think it's a great question. And I actually think it's an opportunity for collaboration, right? So I was thrilled when I was invited to speak here because I think this does require kind of protocolizing our pathways. So as you mentioned, you know, bilateral carpal tunnel syndrome, there can be a protocolized pathway. And I think peripheral neuropathy is probably the other, and or lumbar spinal stenosis or other diagnoses you see. I think the biggest thing when encountering these non-cardiac diagnoses are actually screening for cardiac symptoms, right? That doesn't always occur unless someone's seeing a cardiologist, which they may never get to. So if encountering a patient with a non-cardiac red flag, do they actually have undiagnosed heart failure or heart symptoms that should prompt referral to cardiology? So I think that would be very important to establish early on. And then I think age is the other kind of big risk factor. So as you can see, like generally speaking, people less than the age of 50 are not at significant risk of TTR amyloid. It's isolated. And so I think using age plus the combination of are there cardiac symptoms present to prompt screening is important. But I would personally, in my role, would love to collaborate with your department to actually put this down in writing, right? I think we go to talks and some of it retains, some of it doesn't. So I think we should, I would love to work with your department to actually have dedicated screening pathways. I think this is probably the way to move the needle forward here at Hopkins.
I think the other area is tendon ruptures. I have talked to other amyloid patients who had Achilles tendon ruptures, just spontaneous. And I think that may be a group that needs to be studied to make sure they don't have amyloid.
Great, thank you.
Outstanding presentation, Dr. Vaishnav and Dr. Rakra. Thank you so much for being here today. One of the things that I was struck by is, we talk a lot about the identification of this, like oftentimes later in life. But if we were to screen younger populations, would we see these traits in children? It's through the lifespan, right?
It is, yeah. I think age is a very potent risk factor. So generally adulthood and even the early onset neuropathy variants does not affect pediatric patients. So I have had pediatric patients worked up for neuropathy and had a TTR genotype sent, and in fact, it's positive, but I have never attributed childhood neuropathic disease to TTR. I think early identification is depends on the patient, good or bad, in terms of knowing that you have a future risk for this disease. So we generally do recommend cascade screening if you're within 10 years of a family member's diagnosis or above the age of 50. And I think even early onset variants, probably 30 and above, is the cutoff that I think of.
Yeah, thank you very much. I know Kelly Daly, she was on earlier, our informaticist. We have already been starting some of the discussions about how we could potentially link in some of the screening questionnaires, the tier 1 and tier 2, into a flagging process, so that when a provider would then log in, if somebody had identified with those, that it would at least spark the provider to inquire, dig a little deeper.
Absolutely. Yeah. And I think that addresses one of the questions in the chat, which is, how can, as therapists, we best help patients? Are we routinely checking for it? Not all, we are not at Hopkins even routinely checking for it. So I would love, again, to collaborate to streamline those pathways.
I feel like with the numbers of patients and the population that we serve in Baltimore, the number of lives that could be saved by implementing some of these simple awareness procedures could be profound.
Absolutely.
So,
absolutely.
I know our ambulatory, there's a group in ambulatory that is hoping to have some more outreach and community education coming in the spring, in the summer. And yeah, we really appreciate your support in helping to educate us and prepare us for this. It's really outstanding.
Absolutely. Thank you guys so much for having me and listening to this for the past hour. And please email me, offline if you guys have more questions, patients you want to run by our group. Always happy to help.
Thank you again. Thank you both.
Yep. Thank you guys.